Welcome, everybody, and thank you so much for having me present in this course. My name is Rebecca Rowe, and I am your student DMP for this course, which is the Pathophysiology Nurse 3403. And my presentation today is going to be about reproductive disorders for the male and the female. In your D2L content, you have a variety of information and presentations available to you. So I'm not going to go and try and present some of the things that are already there. What I'm going to do is try to give you some overviews of common issues we face today in reproductive health. And after this presentation, you have a activity that will allow you to gain some further information and some time learning about the most recent statistics in sexually transmitted infection or STIs in the CDC site, and how you can see how our state and local communities within the reach of the University of North Georgia fare. This is not a graded activity, but you will use the site many times during your career. I've used it a lot, and it's very helpful, especially when you're looking for statistical data and seeing just exactly what kind of epidemiological data is covered throughout the nation and throughout our state, and how our statistical information is kept and reported. So it's very important that you all get a chance to look at that and just get a chance to look through each page in that particular area. It's interesting. So objectives today are on the female disorders, what we're going to start with, and we're going to discuss common disorders of the female reproductive tract. We're also going to explain some important aspects of assessment of the female regarding reproductive disorders, and then discuss treatment modalities used in female reproductive disorders. And the three areas that I'm covering are going to be endometriosis, uterine fibroids, and ovarian cysts. And I'm covering these three topics because they're so common and so many women suffer from these maladies, which can affect the health and quality of life for these women. And some of you out there in the audience may actually have some of these issues yourselves. It's very widespread. So I hope this is helpful for you. There's a concern over the decreasing fertility rates, and you hear it discussed by government officials around the world. And because if you think about it, the future of our world depends on our generation's ability to support the next and replace some of our population that has passed on. And so some of these diseases can affect this decline, and we will finish our presentation with some very recent information regarding work on that perspective. So let's start with endometriosis. Endometriosis is the abnormal location of tissue that is similar to endometrial tissue that's found in the uterus, but it is deposited outside of the uterus. And it responds like endometrial tissue cyclically during the menstrual cycle. So, those areas where you normally have an egg that's deposited in the wall of the uterus, it's not fertilized, the uterine wall, the endometrium sheds, you have bleeding through the vagina. In this particular case, where this endometrial tissue is deposited outside, you can have bleeding outside. That blood is deposited in the pelvic cavity, and so it can become further implanted in other areas in the body. And that's why you find it some places in the uterosacral and broad ligaments, the bowel, the bladder, and even other locations like the lungs that are very unusual. But you can find them even in the brain. Researchers have not yet determined the exact cause of endometriosis, but it can destroy a woman's quality of life with debilitating and painful symptoms. And many women have no symptoms, or they think that the symptoms that they do have are just a part of what a woman is supposed to go through. So some physicians may think that the symptoms are psychosomatic, and the patient may just not seek any further help until the disease becomes unbearable or it's corroborated by a different condition requiring treatment, and they find it on a completely happenstance situation. So the symptoms include severe menstrual cramping and pain, nausea, vomiting, back pain, fatigue, bloody bowel movements or blood in the urine, painful bowel movements, painful urination, painful sexual intercourse, migraine type headache, and excessive bleeding during periods. And an increasing number of women with endometriosis experience infertility, but there's not a definitive reason. And it's thought that maybe the ectopic endometrial tissue over time forms scar tissue and adhesions, which are like tiny bands of saran wrap, if you can imagine, that obstruct or impair the fallopian tube's motility, which helps the ovum reach the uterus. And there also can be a long diagnostic delay. Sometimes women have reported somewhere between 7 and 8 years after the onset of symptoms before a doctor will ever diagnose that they actually have endometriosis. And it takes persistence and these recurrence of symptoms to drive a female to seek multiple opinions and to continue to seek treatment. Endometriosis is a multi-system disease. Patients with the condition should ideally be offered some kind of personalized, multimodal, interdisciplinary treatment approach. And the treatment is basically managing the disease, and the diagnosis depends on the staging of the endometriosis. The later the stage, the more radiographic imaging can inform providers of the extent of the disease. The earlier types of endometriosis uh, are definitely diagnosed by laparoscopic surgery. So the treatments are all about managing the disease because there's no cure. And the information states that it can take as long as 7 to 8 years to get a diagnosis. And while the patient waits for that, possibly some form of treatment is happening along the way. So, what can be done to manage those symptoms? So, you must remember that some of the symptoms patients describe mimic other conditions or diseases. Some of those symptoms are often mistaken for ovarian cysts, uterine fibroids, pelvic inflammatory disease, even irritable bowel syndrome, sometimes mental disorders. The protocols are slowly taking effect that give a process for providers to follow. And one is pain control, and alternative methods are listed here. And over the counter pain medications include NSAIDs that help with pain. And there's also alternative therapies like yoga, meditation, of course, heat applications, and acupuncture can also be added to the regimen to help manage pain. The second treatment is hormonal therapy. Birth control, contraceptives, those can be used. Sometimes the contraceptives have a combination of estrogen and progestin. Those come in multiple forms, including oral birth control pills, patches, vaginal rings, birth control shots, implants, or even IUDs. And this treatment often helps people have lighter, less painful periods. Some medications that are used are gonadotropin releasing hormone agonists, and those medications stop hormones that cause the menstrual cycle. And this basically puts the reproductive system on hold to relieve pain if it's that severe. Those agonists can also be used to create this reduction in estrogen. And patients need to know that this will cause menopausal symptoms like hot flashes, dryness in the vagina, decreased sexual drive, and potential bone loss, osteoporosis. So it is important to know that some of those things may have some detrimental effects as well as helping with the endometriosis symptoms. If the patient is trying to get pregnant or may be pregnant, there must be a discussion with their provider before any of this treatment is started because it could have an effect on the fetus or with their ability to conceive. The third and most definitive treatment is surgery, and this depends on the severity of the disease. The surgery will most likely be performed laparoscopically to diagnose and resect the endometriosis implants, perform a lysis of adhesions if they exist, and inspect for any other organ involvement or damage caused by the endometriosis. There are options for ablation therapy, laser, and other devices that can be used for fine resection of the endometrial implants. And the patient should know that total hysterectomy with removal of tubes, ovaries, and the uterus is a final step along the pathway if other treatments are not successful. So there is a classification of endometriosis, and there are the stages, and there are more than one, but I'm going to talk about the one that the American Society of Reproductive Medicine, or ASRM, has determined is probably the most commonly used. Um, Stages don't always correlate with the severity of the symptoms the female is experiencing, and nor do they really talk about the complications with organ systems. What they do is tell you how far the endometriosis has spread. So, stage one minimal disease has a small amount of these brownish, blue, black, white, or clear implants, and they're given a point spread of 5 or less. And then stage two is mild disease, and this is deeper and more implants than stage one, and that goes with 6 to 15 points. And then stage three is moderate disease, many deep implants, small endometriomas or on ovaries, and some filmy adhesions, which garners 16 to 40 points. And then stage four is the severe disease with many deep implants, dense adhesions, and those adhesions may adhere to the back of the uterus, even into the rectum. So that's 41 plus points for those stages. So there are other staging criteria that are used. One's called the Enzian classification system that uses imaging to choose between 8 different designations. And then the Endometriosis Foundation of America classifies the disease based on its location within the pelvic and abdominal cavities by 4 categories. So there's lots of different ways that providers can stage this endometriosis. So I want to explain a couple things. Ovarian endometriomas form when endometrial tissue attaches to an ovary. And as the tissue sheds, it collects along this old, thick brown blood. And sometimes those are considered chocolate cysts because the consistency within that cyst looks like liquid chocolate. Filmy adhesions, those are those thin bands of scar tissue that form, like I told you, is like saran wrap, and they can cause a lot of problems in response to the body's attempt to protect itself from inflammation. These bands are formed. They can also form because of surgeries that are used to diagnosis, multiple surgeries, multiple entries into the abdominal or pelvic cavities. The body protects itself by forming some of these adhesions. They tend to make organs stick together, and they can cause sharp stabbing pain as well as other symptoms depending on their location. So, when a physician or surgeon enters into the abdominal or pelvic cavity with a laparoscope trocar, many times the adhesions will look like large spider webs within that cavity. So they have to be very careful upon entry to make sure that they're able to dissect those adhesions, or they may have to do an open procedure to be able to visualize the internal organs more efficiently and not cause any damage to the internal structures. The next topic we're going to focus on is uterine fibroids, and these are benign growths developed from the muscle tissue of the uterus. And uterine fibroids are benign, they're not cancerous growths, and they can develop from the muscle tissue of the uterus. They are also called leiomyomas or myomas. They're the most common type of growth found in a woman's pelvis. The size and shape of fibroids vary greatly, and I've seen some that are as big as a bath basin, um, and very heavy. And you wonder how women can tolerate carrying these things around because they are like carrying a pregnancy to full term. The size and shape can vary greatly and range from the size of a pea to completely fill the pelvis or the abdomen. They can occur at any age, but they're most common in the age of 30 to 40. They occur more often in black women than white women, and they seem to occur in younger black women and those women who have they grow in a much quicker pace. So it's not certain why that happens, but one of the social determinants may be that there is some racism or inequity that play a role in how soon black women seek treatment or have access to care. So that's something to keep in mind when you see some of these rates of different diseases and some of the onset of some of these diseases. As in endometriosis, there is a familial connection. Endometriosis also runs in families, so does uterine fibroids. So it's good to obtain when you're doing an assessment on patients to get a good family history, and you'll see good family histories from your nurse practitioners or your providers when they first meet these patients. You really want to find out what's going on with the family and see if there's any genetic or familial um, hereditary factors involved. The one thing that separates uterine fibroids from the endometriosis condition is endometriosis can lead to some endometrial cancer or uterine cancer. Uterine fibroids, not so much. So we have some different types of fibroids that can be identified, and they have four distinct characteristics in their growth patterns. The submucosal fibroid develops below the mucus lining of the uterine cavity. The subserosal fibroid develops outside the uterus and continues to grow outside of the uterus into the pelvic cavity. The intramural develops inside the uterine wall and may make it larger, or the female may feel very bloated. The pedunculated fibroid usually has a stalk, or the fibroid hangs from this connection to the inner or even the outer uterine wall. And you'll see this term pedunculated also in the ovarian cyst category. So, what causes uterine fibroids? Could it be estrogen and progesterone related? Could it be misplaced cells in the body before birth? No one knows for sure. Some research suggests that these things were formed before we were born, females were born, but no one knows for sure. These are all theories. So when a woman reaches menopause, those fibroids actually can shrink to a decreased level of estrogen. So that is what's leading people to believe that estrogen, of course, causes some of these different factors in the uterine lining growth. And so when you look at what the progesterone and estrogen do in this slide, you can see that there is a difference in the two hormones. And so it leads people to believe that estrogen is related to the growth of the fibroids. And like I said, fibroids are rarely associated with cancer, but it's important to access regular medical examinations to ensure early recognition and management, because these are space related things. You're wanting to look to see if these fibroids are uh, preventing a female from becoming pregnant or causing them very much pain in sexual intercourse or having a fulfilling sexual relationship with someone. It's very important that for everyone's health and their space relation and their overall pain control that these fibroids are assessed and monitored. If patients are on contraceptives with estrogen, you may see the fibroids grow more rapidly or an increase in size. So that too leads to the hypothesis that estrogen and progesterone have a direct effect on the growth of these uterine fibroids. Your fibroid symptoms are concentrated into three major categories. They're listed as changes in menstruation, pain, and pressure. And when you're talking about menstrual changes or changes in women's periods, women with fibroids may have longer, more frequent, or heavier periods. They experience cramping, menstrual pain, and they may experience anemia associated with vaginal blood loss that occurs other than during their regular menstrual cycle. And anemia is another topic that should be investigated worldwide because women notoriously have anemia, and usually it's because of blood loss during menstruation or because of some of these other disorders we're talking about today. Pain can be dull or sharp, achy, radiating from the abdomen to the back, and many times sexual intercourse is painful. Rectal pain can also occur depending on the location of the fibroid. And if the fibroid has that stalk or is pedunculated, like I said, the stem can twist and cause severe pain in the location of the pelvic cavity where that fibroid is growing. Pressure from the size and location of the fibroid can lead to constipation, rectal pain, difficulty evacuating your bowel, frequent or difficulty urinating or fully emptying the bladder. If the fibroid grows large enough, it can resemble a pregnancy with the pressure of that fibroid in the uterus or on the uterus projecting into the abdomen and putting pressure on other internal organs such as the bladder or the bowel. Miscarriages can occur if the fibroid has taken over the space in the uterus, and there is an implantation and fertilization of the ovum. It's not allowing the fetus to grow, and so that can cause miscarriage. Infertility can also be experienced due to uterine wall issues. And the one thing about infertility in the case of fibroids, if it is treated and the fibroid is removed, amazingly, some women have no symptoms and they can get back to getting pregnant once they're treated and the fibroid is removed. So some women have no symptoms at all, which is hard to believe, but there is a TV show saying I didn't know I was pregnant. So I mean, there are things that exist in the world, and some women just have no symptoms at all, and then they're discovered on routine pelvic examination. Very large fibroids do cause abdominal swelling, and it makes it very challenging to do a proper and thorough pelvic exam on these women. They're diagnosed with a variety of options. Ultrasound is one of our main tools for diagnosing fibroids. Ultrasound of the abdomen uses sound waves, of course, to show the uterus and other pelvic organs. You can also use a sonohysterography, which is also an ultrasound where fluid is placed in the uterus through the cervix, and the ultrasound uses the fluid to form a clear picture of the inside of the uterus. Hysteroscopy can be performed as a diagnostic tool and also as a fibroid removal tool. It's a small instrument with a light, irrigation, and a camera that can actually visualize the interior of the uterus, show any fibroids, show any changes in the size and shape of the uterus and the fallopian tubes through a laparoscope. So you can do all kinds of things with different types of scopes. Hysterosalpingography is a radiologic exam, and that helps show the tubes, uterus, and the ovaries. A surgical procedure that you will see done very commonly is a myomectomy, and for radical situations, hysterectomy can be performed. Um, if the fibroids cannot be safely removed, they also use ultrasounds intraoperatively. Transvaginal ultrasound is our key thing there to make sure that we use a minimally invasive approach and we're able to check for fibroids that may be outside of the uterus. So non-surgical procedures are growing in popularity. The one thing I have to stress with you, everyone, is that the ability to get pregnant after these procedures has yet to be clearly determined. And these procedures are called a uterine artery embolization. This is usually done on an outpatient procedure where tiny particles, it's about the size of a sand, are injected into the uterine vessels that supply blood and oxygen to the uterus. This uh, cuts off circulation to or blood flow to the fibroid and causes it to shrink. Another one is radiofrequency ablation, and this uses energy and heat to shrink the size of fibroids. Ultrasound, laparoscope can be performed also. They can visualize the fibroids where needles are placed in the fibroids and heat is added to destroy the tissue, and this can be performed vaginally or through the cervix. Beyond those procedures that are a little bit more invasive, medications can be used to decrease heavy bleeding, and this goes back to some of the same medications that are used with endometriosis. Contraceptives, sometimes these meds will cause increased growth in the fibroid. Some of your gonadotropic antagonists do not shrink the fibroids, but they may be used for heavy bleeding, and they suggest using those for about 2 years maximum. They do help with menopausal symptoms, and your gonadotropic agonists may be used to stop the menstrual cycle altogether. These meds can shrink the fibroids, but they can also cause osteoporosis, vaginal dryness, night sweats, painful cramping is involved with your progestin releasing IUDs, and they can be used in women who do not have fibroids in the uterus. but they can be used for the cramping and excess bleeding um, in normal non-fibroid related situations. Tranexamic acid is used to treat heavy bleeding and it reduces the blood loss during menstruation, but it does not stop periods. The next issue we're going to talk about is ovarian cysts. And most ovarian cysts develop from tissues formed during normal menstrual cycle. These factors influence the formation of cysts include hormonal imbalance, including fertility drugs, pregnancy, endometriosis or growth from endometrial cells, which are found out inside the uterus on the ovary, a pelvic infection that spreads to the ovary, which would be pelvic inflammatory disease, or a previous ovarian cyst. And the cyst is actually a fluid filled sac or pocket in and on the surface of the ovary. It's very common. Greater than 3 million cases per year in the United States alone are diagnosed. They're usually harmless, usually no symptoms, but would they become very problematic if that cyst can rupture. And one little point I can make is that from a surgical background where I come from, ovarian cyst ruptures can be extremely dangerous and they can become a medical emergency. So a large one can cause you to bleed very heavily and hemorrhage. So internally, so that is considered a medical emergency, and those patients are brought straight to surgery for the removal of the cyst if they can, or possibly removal of the ovary itself. Most ovarian cysts cause no symptoms and they go away on their own, but a large one, like I was telling you, can cause sporadic pelvic pain. You can have dull, aching, or sharp pain in the area below your umbilicus towards one side or the other. Fullness, pressure, or heaviness in your belly, a bloating abdomen. It can also mimic a ruptured appendix. So a lot of times when patients come to the emergency room, they may have a fever, they may have right-sided quadrant pain, and it mimics appendicitis or a ruptured appendix. Usually, when an appendix ruptures, that appendicitis pain is immediately relieved, but that sets up peritonitis and some sepsis issues that also preclude anything else, and that patient has to have surgery relatively quickly. So in this case, you rule out both of these things, and the diagnostic laparoscopy is what is performed on these females that come in with that type of thing. They do ultrasonography also to check and see about the appendix and also the ovaries. If they experience sudden severe abdominal or pelvic pain, pain with fever or vomiting, signs of shock, cold, clammy skin, rapid breathing, lightheadedness, or weakness, they need to seek immediate attention. That is a surgical emergency, and these patients should know that they could possibly have that affected ovary removed, and that is called an oophorectomy. And removing an ovary could possibly increase issues with infertility for the female. Um, and if both ovaries are removed for whatever reason, early menopause is going to happen, and they'll have to be on some form of hormone replacement therapy. So, diagnosis, the pregnancy test might suggest an early pregnancy, but it can also be indicative of a ovarian cyst from corpus luteum cyst. Those are normal to see during pregnancy. A pelvic ultrasound, we use a wand-like device that sends and receives high-frequency sound waves to create an image of the uterus and ovaries on a video screen. And this image is used to confirm that the cyst exists, where its location is, and determine whether it's solid or filled with fluid. A laparoscopy is a slim, lighted instrument. It's inserted into the abdomen through a small cut or incision. And using that laparoscope, your provider can see your ovaries and any cysts. If the cyst is found, treatment is usually done during the same procedure. You can actually have the cyst if it can just be removed by itself and not removing the ovary. They can just remove the cyst itself. Um, and they can also look for cancer markers or tumor markers. And the reason why your provider might order a cancer marker or 125 or CA 125 test is they can be elevated in non-cancerous conditions such as endometriosis and pelvic inflammatory disease. So this also helps the provider make this diagnosis. There are many types of ovarian cysts, and the chart that's in this slide shows you different types. Interestingly, if there is a dermoid cyst, that cyst may, when it once open, may show that it contains hair, bone, or even teeth. So on treatments of ovarian cysts, they may decide to just wait and see what happens with this cyst, and they'll use ultrasound and pelvic exams to just monitor and manage symptoms and watch for the growth of that cyst. And like I said earlier, um, they may go away on their own. So it takes that specific type of management to make sure that those cysts are monitored carefully. Medications like your hormonal contraceptives to inhibit ovulation, they don't shrink uh, the cyst, any existing cyst. Surgery requires removal of the cyst. It would be an ovarian cystectomy. Removal of the cyst in the ovary, which would be an ovarian cystectomy, the oophorectomy. And most approaches are laparoscopic and minimally invasive, like I talked about before. If the cyst is extremely large, a larger incision may need to be made to be able to remove that cyst. Ovarian cysts that develop postmenopausal can be sometimes cancerous. So you have to be careful with that for older women that have ovarian cysts that are diagnosed. The patient may expect to have more extensive surgery if they send a culture or a specimen to the lab or pathology and they determine that it's suspicious for cancer. They may have to do more extensive surgery to remove the pelvic organs, such as the uterus, the cervix, fallopian tubes, and ovaries, and then follow up with chemo or radiation therapy. Remember, no matter what age, when ovaries are removed, the woman should expect to go into menopause if they haven't already. Hormone replacement may be necessary for these women. So there is some follow-up treatment that must be provided for these women. So that concludes the female reproductive health. We're going to move into our male reproductive health situation here. So consider this that there could be a male counterpart to gynecology. Is there one, do you think? Yes, there is, and it's called andrology. Andrology is a growing branch of medicine. It's not yet widely recognized, but it is the male counterpart of gynecology, and it is evaluates anything that's related to male sterility and infertility. And this has become a very big topic globally because our population is diminishing and male infertility separate from female issues is increasing. And so it's alarming. This is male infertility is like the canary in the coal mine. Everyone is trying to figure out what is going on. And currently, our urologists are the most commonly sought medical services for male reproductive health issues. But this specialty, the andrology specialty, is slowly taking its place in mainstream where we're talking specifically about fertility and infertility issues. And this should bring about a little bit more of our collaborative and coordinated care for our male counterparts. So the objectives in this particular section have to discuss common conditions that affect the male reproductive system. And we're going to discuss some of the um, hormonal glandular connections to that male reproductive function and list some commonly used medications that interfere with male sexual function that you would not believe do that, and then review current global status of male reproductive health. And there's some really good current studies that are out there now that are taking place that we're going to talk about some of those interventions that are being planned. So, male reproductive issues can have a significant impact on man's overall well being and quality of life. And male sexuality determines the true north of a male being. And I really did not seem to grasp the magnitude of that until I started working with males who had benign prostatic hypertrophy or hyperplasia and started working with them on a clinical trial for a new surgical procedure that we were undertaking a few years ago. And it became very clear to me how important sexual function for a male is on their mental and physical well being. So we're going to get into that just a little bit. So we're going to look at some of these common reproductive issues. We're going to take these issues one at a time and look into them. The first one is erectile dysfunction or impotence. And this refers to the inability of the male to achieve or maintain an erection sufficient for sexual intercourse. And there are various factors that are involved in this situation. It could include underlying medical conditions such as diabetes or high blood pressure, as well as psychological factors. And you know that diabetes and hypertension is rampant in our society today. ED is not a normal part of aging and it should not be ignored. Medical examination and consultation can determine underlying causes and help determine treatments that are the most appropriate for the patient. And those treatments can range from medications such as your Viagra's and your Cialises to penile injections to penile prosthesis and even vacuum assisted devices, if you can remember the movie Austin Powers. So, to lifestyle and changes and counseling. So, there's a lot of things that are out there that men, if they can seek out consultation with a, a provider, can actually help them with this situation. Premature ejaculation is the second on this list, and it's a common male sexual problem characterized by the inability to control ejaculation during sexual intercourse. And this can truly impact sexual relationships. Anxiety, stress, as well as hormonal imbalances can contribute to premature ejaculation. Currently, there are several options available to men. Behavioral therapy is one of the major ones, being able to focus and um, work on some biomechanical issues with ejaculation. Using medication and counseling can help address those underlying psychological issues like depression that may be contributing to the issue. Your low T or low testosterone, also known as hypogonadism, can result in a range of symptoms, including fatigue, your decreased sex drive, reduced muscle mass. Many factors can contribute to low testosterone, including aging. Certain medical conditions and lifestyle factors, such as obesity or excessive alcohol consumption, play a part in low T. It's important that men get regular physicals to test for a variety of issues, but also to confirm this diagnosis because it is treatable. Treatment options for low testosterone levels include replacement therapy, which can be administered through injections and gels, patches, or pellets, in addition to medical intervention. Lifestyle modification, your regular exercise, healthy diet, and it can also help improve testosterone levels. And if you're wondering why testosterone is not in an oral form, and you hear advertisements about this a lot, I'm not quite sure what those drugs are because they're not the prescribed drugs, those are over the counter things. But most testosterone, about 50%, is metabolized on its first pass through the liver. So if you were giving this orally, you would not get the effective therapy desired. So that is why that testosterone replacement therapy that is prescribed by physicians is not given in an oral form. Prostatitis is on this list, and this refers to inflammation of the prostate gland, and this can cause urinary symptoms and pelvic pain. There are different types of prostatitis, including your acute bacterial prostatitis, your chronic bacterial prostatitis, and your chronic pelvic pain syndrome. One thing you should know about prostate infections is they're very hard to eradicate. Bacteria love living in that prostate environment. It's dark, it's moist, love that word, and they just like living there. And so sometimes men are on long-term antibiotic therapy. Maybe in your acute phase, they're on a 10-day run of antibiotics. They stop taking it, it comes back again. So in these cases where you have two or three more prostate infections or prostatitis, you're going to have swelling of that prostate gland, which occludes the urethra. It causes swelling temporarily until this infection is under control. This is not the same as BPH. This is an infectious process. So what you're trying to do is to make sure that the antibiotics are in the system long enough to well they will eradicate the bacteria. For chronic pelvic pain syndrome, treatment may involve pain management techniques, hot baths, physical therapy, as well as lifestyle changes to reduce stress and inflammation. And the last things that are on this are testicular disorders, and these include a wide range of conditions affecting the testes, such as testicular cancer, testicular torsion, and testicular injury. And you can see this a lot in young men that are especially active in a lot of sports. And we'll talk about a little bit about that. Well, like I said, in your slide in your D2L, there are already very detailed slides on some of these conditions, and I'm just giving you a basic overview of some of these things. But I want to tell you that testicular cancer occurs in young males in their productive years. And so this is, somewhat, of a tragedy for some males that have this. Unfortunately, it is not a very common cancer, but it is one that affects that age group. So I have to tell you that. And early detection and being able to do, just like women do breast inspections, men should do scrotal inspections of the testes. So you should check out in your med surg textbooks or whatever, they give you specific guidelines on how to do your own scrotal checks to feel for any lumps, hardness, nodules, painful knots, or anything that are not supposed to be in your scrotal sac. So I would highly encourage you to take up the mantra of doing especially after a warm shower, making sure that everything is working down there and that you have test your scrotal sac. So early detection is crucial. Treatment options vary depending on the specific condition. Testicular cancer, for example, may require surgery, chemotherapy, or radiation therapy. Testicular torsion, which is a condition in which the testicle twists. It cuts off its blood supply, requiring immediate surgical intervention to prevent permanent damage. And I have seen this happen many times to young males. It usually happens late at night, maybe in their sleep. They'll wake up to excruciating pelvic pain or scrotal pain, and those maybe they get very nauseated, they vomit. Um, and they can feel there's a twisting in that spermatic cord. And this is usually after a day of really strenuous activity or sports activity. Testicular injuries may require surgical repair or other appropriate intervention. So, what happens in the torsion when they come to surgery is we have to go in there and make a small incision. We have to open that scrotal sac, and we have to make sure that testicle is stitched down so that it doesn't twist again. And sometimes this is also passed down in the family trait. So a good family history is also very, very important. Hormonal imbalances, some of the causes. There's a variety of factors, including physical, psychological, and lifestyle related causes. And understanding these causes is a crucial step in managing and treating the associated reproductive issues. So, some of the physical causes are hormonal imbalances, for example. They can disrupt the delicate hormonal system of the reproductive organs. And we all know that the pituitary to the testes regulate some of those glandular releases of hormones throughout the male anatomy. Additional underlying medical conditions, including diabetes or cardiovascular disease, may impact reproductive health. And certain genetic conditions, such as Klinefelter syndrome or cystic fibrosis, can affect male fertility by interfering with the production or transport of sperm. So, seeking that medical advice and genetic counseling also is an adjunct to help individuals with these conditions understand their reproductive options and to make informed decisions about their future treatments. Psychological factors can significantly impact male sexual function and contribute to reproductive issues. Stress can disrupt the delicate balance of those hormones we talked about involved in sexual arousal and performance. And anxiety or relationship problems can also create psychological barriers that hinder sexual satisfaction and reproductive success. Mental health issues, including depression or performance anxiety, can further complicate matters. These conditions can lead to erectile dysfunction or premature ejaculation, making it challenging for individuals to achieve and maintain a good, healthy, satisfactory sexual experience in relationships. Addressing and managing these psychological causes is so important to improve the overall sexual health and function of both male and female partnerships and male to male partnerships, for that matter. It's just extremely important that everyone is supportive of each other because these situations and dysfunctions are common and we need to be aware and open to be able to discuss them without judgment or fear of um, judgment. Lifestyle choices can have a profound impact on our reproductive function. Obesity, for example, can disrupt hormone production and impair sperm quality. And I'm not saying that obesity is a lifestyle choice, but weight management is a choice. So, trying to maintain a good weight for your body habitus is important. Make sure that your blood pressure and all of those functions that go along with good weight management is important. Excessive alcohol consumption and drug use can also negatively affect reproductive health by impairing sperm production or motility. And we'll talk about that in a minute. And smoking is another detrimental habit. It damages the genetic material in sperm and it reduces fertility. So, environmental exposures to toxins such as pesticides or certain chemicals, even some common medications, can have adverse effect on reproductive function. So, the mantra here is to try and maintain a healthy lifestyle or do the best you can to maintain a healthy lifestyle that can help prevent or improve reproductive issues. Regular exercise promotes blood circulation and hormone balance are needed to optimize that reproductive function. Your diet that's rich in nutrients like zinc, selenium, vitamin C, and E also can support healthy sperm production and motility. Tobacco, alcohol, and illicit drug avoidance can also help protect reproductive health. And like I said, your stress reduction and weight management are also part of that plan to help you with that. In pharmacology, we see that there are many over the counter drugs that we use on a daily basis. And some of these drugs can interfere with sexual function. And this is extremely important that you should know this because you're going to be seeing these and you may be taking some of these things along the way. And so you're going to see some of these. These were surprising to me. So I just wanted to share this with you. This is some pharmacology text from the University of North Georgia. So you're going to see that probably in some of your curriculums. So there is a chart that I adapted for this presentation. So please avail yourself to this. But you can see there's anticholinergics, antidepressants, antihistamines, even Benadryl, hydroxyzine, antihypertensive, your diuretic, angiotensin converting enzyme inhibitors, your alpha 2 agonists, your alpha and beta blockers. Those are commonly used drugs. Antipsychotics, your phenothiazides, your the other drugs, your anti-ulcer drugs like Tagamet, Zantac, famotidine, alcohol, barbiturates, Valium, cannabis, cocaine, opiates, methadone, all those things affect sexual function. And then others like steroids, digoxin, your chemotherapy agents, lithium, and others, those all, baclofen, they all affect your sexual function. But I wanted to talk for just a moment about cannabis. Recently, I went to a conference and had a fantastic lecture by Harvard Dr. Tischler, and I put his website there. I believe he's retiring in September, but of this year. But he has a website, inhalemd.com, INHALEMD.com, and he is of the mindset of treating cannabis as a medicine, not as a recreational type of thing. And he has very, very strict guidelines on how patients should be treated for dependent on what type of problem they're having, whether it's PTSD, whether it's sexual dysfunction, whether it's pain, sleep apnea, you name it. So, what I wanted to tell you is that cannabis doesn't have a lot of long term studies or research that has been separate just on cannabis alone because they have found that most people that imbibe in cannabis also smoke cigarettes or tobacco and also drink alcohol at the same time. So it's hard to do a study on someone who has got those variables in their system already. So more research is needed on this, but we do know from the research that has been conducted that long-term marijuana use, which is becoming more and more prevalent with the legalization of marijuana across many states, that it reduces sperm count and concentration. It reduces sperm motility and viability, which may lead to higher rates of male infertility, which is not what we want to see in the current state of affairs. So, just as marijuana can cause you to be a little bit laid back, it causes your sperm to be laid back too. So, just pay attention to what the research is telling us about cannabis. It is not harmless. It does have side effects that need to be researched a little bit more rigorously, and anesthesia guidelines and some other cannabis specialists have been compiling and collaborating on guidelines to watch for some of these newly found research statistics. So be careful. So this slide is a little interesting because this shows you um, the effect of global prosperity on human fertility. And this is what I was telling you, this is a hot topic now. Our male reproductive health has become a prioritized topic of declining birth rates in the world. It's not just in this country. So it's important to look at this because not much has been spoken until lately about this. We've heard about it, but I told you that male infertility is like the canary in the coal mine. It has an impact on how we replace our population and how we're able to take care of generations to come. It's something to think about when you're looking at, building infrastructures and how we take care of our current infrastructures that exist. Who's going to be around to take care of these things with a limited population? So it's an interesting concept, an interesting conversation to have, but it's something to think about and take into consideration when we look at the increases in diabetes, autoimmune disorders, and other inflammatory or infectious diseases that are prevalent in our society today. And so when you're doing your activity on sexually transmitted infections, I want you to think about this in the context of male infertility and female infertility and what it is doing to the overall future of human race. And look at the hormones, the aging, and genetics, and how these all contribute to the quality of reproductive health between male and female sexes. So I want to thank you. This is for attending this presentation. Male and female reproductive issues significantly impact our quality of life, physically and emotionally, and seeking timely treatment is necessary to diagnose and form a treatment plan that everyone can live with. And open communication with providers and with your partners are truly important to help alleviate shame and procrastination in seeking treatment. Remember, sexuality is part of a normal life, and more treatments are emerging every day to help people get back to this better way of life and a better quality of life. So I highly recommend seeking out that treatment, sharing this information, and thank you so much for attending today.